Thank you for allowing me to speak today. I'm Dr. Baxter. I'm a resident, fourth-year resident, representing our Wake Forest Baptist Health. So to start this conversation off, I put a disclosure. I do receive salary from the company that sponsored this, one of the companies that sponsored the study, Spectral MD. And I would like to acknowledge the Wake Forest Baptist Health System, Dr. Holmes and Dr. Carter, as well as their research staff for helping us complete the study, as well as the government organization BARDA that mostly funded this study. So the current diagnosis of burns, I'm sure everyone in this room knows, it's based on a visual assessment using a variety of techniques, like the quality of the wound, and the color of the wound, the fluid of the wound as well, and more of a wait and see technique. Expert surgeons, research has shown over the past couple of decades that they're about 70 to maybe 80, maybe 85% accurate in determining the initial diagnosis of burns and whether or not they need surgery. If you look at non-burn experts, just a routine clinician, they're about 50-50. So the problem with this is that obviously if they're misdiagnosed needing surgery, the patient will receive unnecessary surgery and perhaps be transferred to a facility without having the need for it. And if they're misdiagnosed as a healing burn, then they have a wound for an unnecessary amount of time. So what we need in the burn community is a way to diagnose burns more accurately. So we need to first identify, though, a method of true diagnosis. And the easiest and most straightforward way is via a histological approach. And this has been previously explored with papers dating all the way back to, I believe, when it was 1949 that I found. But various histological components have been brought up, including the epidermis and dermal structures, as well as the vasculature, interstitial and cellular proteins using various stains, and even looking at the particular shape and damage to the cellular nucleus. But despite all this research, there's still no widely accepted method to diagnose burns on a histological basis. So a brief review, normal skin histology. The epidermis is very top. It varies in thickness depending on the anatomical location on the body. There's no real growth structures to speak of except on the basement membrane. The dermis is divided into two different parts, the smaller part being the papillary dermis, the top of it, that's primary job is to support the epidermis and supply blood flow and nutrients to it, and then the larger reticular dermis, which houses most of the adnexal structures, the structures that contain the regenerative properties of the skin. To emphasize these a little bit more, they generally consist of the basement membrane of the epidermis, the sweat glands, hair follicles, and sebaceous glands generally contain the stem cells. And another very important part of the reticular dermis is the vasculature, of course, to supply the nutrients and blood flow. So from a histological basis, a first-degree burn is generally limited to the epidermis. Visual appearance, pretty easy to diagnose, generally. Doesn't really go past the dimples of the skin. The healing potential is very high, close to 100%, and management overwhelmingly is conservative treatments and pain management. Second degree is the more difficult one of the 3 degrees to diagnose, is generally divided into superficial and deep. The layer of the skin for the superficial is mostly papillary, some reticular dermis, but the appearance from the first degree differs in that there are generally blisters. It's still painful, though, and red. The healing potential of this degree is high, and management usually is best left to conservative measures. As you get deeper, past the papillary dermis and more involved in the reticular dermis, you damage more of the adnexal structures in the reticular dermis, and depending on how much is damaged, the regenerative properties of the skin is left, that determines the healing potential. And then the third degree, is one of the easiest, again, to diagnose because it goes through both layers of skin. It's very leathery in appearance and dry, and it's insate. The healing potential is very low, so it usually requires excision and grafting based on the size of it. So taking all of this into consideration, in our study, we tried to determine, based on prior research, the best way to divide all of these, essentially 4 different degrees of burns. So our decision was to draw a line right here between superficial and deep, and label those above the line as healing, and the ones below the line as non-healing, based on the presence largely of the adnexal structures. A brief summary of the study design. Patients were enrolled within 3 days of their burn injury. Burns were taken, all burns in the study were decided to be taken for excision and grafting. Biopsies were obtained in the operating room before the excision, and then each biopsy was sent for histological analysis. The inclusion-exclusion criteria, all patients were over 18. There was limited to thermal burn mechanisms. Burns over 30% TBSA were excluded, as well as burns on sensitive portions of the body, including the head, the hands, and other sensitive portions of the body. So biopsy collection in the operating room. Generally first, the site for excision was selected, and the biopsy was obtained using an 8 mm punch biopsy, because this tissue was going to be taken away anyway. It would provide the best tissue for histological analysis. And this just summarizes again how it was taken. You can't see it very well, but a biopsy guide was placed to help standardize the distance between the biopsies. And we tried to encourage the staff to get biopsies within various appearing areas of tissue. You can see here some was taken on the edges of a white area, more on the red area as well. This was the decision tree that we gave the pathologist, the histopathologist, who also helped develop the decision tree. So we wanted to find a way to get from the excised skin tissue to these 4 burn degrees. The first thing that we asked them to look at is the epidermis, whether or not that was intact. If it is, it's a first-degree burn. If not, we say look at the next layer, the papillary dermis. If that's intact, it's pretty easy. Again, it's a superficial second-degree burn, high healing potential. If that's not intact, go 1 layer deeper to the adnexal structure domain. And if that's not intact at all, if it's completely gone, it's a 3rd-degree burn. But if that is intact, you look to see how much of the adnexal structures are left, which is the most subjective part of the whole tree probably. And if half are left, if half remain, then it's more likely a superficial second degree. If over half are destroyed, it probably won't heal, and it's a deep second-degree burn. And again, these are healing and these are non-healing. So enrollment in this study, we included 17 patients who had burns taken to the operating room, totaling of 26 burns and 186 biopsies. The amount of first-degree biopsies were 0, because all these burns were excised. And generally, I wanted to point out we had 84% male, mostly a white population. Flame was the mechanism of burn injury that was the highest. And of the 3 degrees besides first, 3rd-degree burn was the lowest one found histologically. So I have a few examples. This particular burn was deemed clinically as indeterminate, but most likely obviously needed an excision, taken to the operating room, and I wanted to point out these 2 burns here. One was taken, as you can see, on a more brown area, more leathery area, and one was taken on the whiter area up top. The whiter area came back histologically as superficial second degree, mostly because of the adnexal structure shown by the red arrow. So a viable adnexal structure, and I can't include it because I don't have enough room, but greater than 50% of these structures were left in this biopsy. Similarly, with this worst appearing area, the superficial second degree was observed with a relatively shallow adnexal structure. The next example is pretty similar, is an indeterminate burn, pointing out both of these biopsies. The first one, again, is superficial second degree, but this one is a little bit different. It's a deep second degree, and the second arrow is pointing out a dead adnexal structure, a necrotic one. And deeper, if you could see, there are viable ones in this biopsy as well. And I want to demonstrate that here. This example was deemed a little bit worse. A 3rd-degree burn, flat out, needs excision for sure. And one biopsy I wanted to emphasize, although all of these biopsies were deemed deep second degree, but I wanted to show that up top, the superficial portion of this biopsy had no visible adnexal structures at all. The collagen looks really damaged as well. And if you go a little bit deeper, about 2.5 millimeters, you see still viable vasculature, as well as some other components of adnexal structures, making this a deep second degree biopsy. And then the last example was also deemed a third-degree burn, but I chose this one to emphasize or to show the heterogeneity of the histology of burn wounds. All of these burns were taken from tissue that looked pretty much the same, but the one shown here was a superficial second degree with minimal damage noted on histology except for the epidermis being gone. This biopsy was deemed a deep second degree with also some collagen damage evident, superficial adnexal structures, but deeper they're viable. And this biopsy this is the best picture I could obtain of this slide, actually. There's hardly anything left of this epidermis here to speak of. So it was a third degree biopsy, one of the few ones we had. So overall, total biopsies read as non-healing were about 58% of the study. Biopsies with all non-healing burns with all non-healing biopsies, were about 15%, so all of them were deep second or third degree. Burns with mixed biopsies, or the heterogeneous healing and non-healing biopsies, were essentially half of them. And then burns with no non-healing biopsies, so biopsies superficial second degree, were about 26% of all the ones excised, meaning that 74% of burns that were excised had at least one biopsy deemed as non-healing, which would go along with the known accuracy of burn surgeons, 70 to 80%. There were some limitations I wanted to point out with the study. Histological analysis still needs a lot of work. All of these burns were excised, meaning that there was no control to see which histological features would lead to healing and not healing. All of this evaluation histologically may be considered subjective depending on which pathologist is looking at it. There's also various combinations of adnexal structures and skin thickness depending on where you are in the body. And patient age and other chronic conditions may lead to a false reading. So in conclusion, yet again, the correct diagnosis of burn wounds is difficult. The histological heterogeneity of these burn wounds is frequent and also really complicates the matter. So before we use this system or any kind of system, we need to focus and make a really dedicated study to determine an adequate and appropriate path to determine histology. But ultimately, any diagnostic methods like laser Doppler or other kind of imaging should be based on the true diagnosis method, whatever that is, in this case, maybe histology.
Thank you for the introduction. Good morning. I'd like to thank the SMA for the opportunity to present here at the Southern Regional Burn Conference. Screen. Thank you. I have no disclosures to address, so let's get started. Readmissions are an important measure in the quality of patient care and an important preventable component in healthcare costs. In 2018, Hodosevich et al. Published a paper characterizing the adult burn readmission rates for the United States from 2013 to 2014 in the nationwide readmission database for adult patients. Of the 42,000 adult burn patients discharged during these years, 3,200 of them, or 7.5% of the patients, had unscheduled readmissions. Of these unscheduled readmissions, a little more than half of these were for burn-specific reasons, making the unplanned readmissions rate nationwide for burn-specific reasons 4.1%. However, due to the nature of the study, they were unable to fully categorize the burn-specific readmissions as pain or infection or otherwise. So we specifically were interested in knowing the readmission rate for pain related to patients' burns, since, as we are aware, the opioid epidemic was officially declared a public health emergency in 2017. This led to federal and state legislations regulating limiting the prescription of opioids. Specifically in Florida, the Florida Controlled Substance Bill was passed in July 2018, and it limited Schedule II opioids to 3-day supply or a 7-day for acute pain exception. Pain for burn patients is difficult to manage, even with the implementation of non-opioid alternatives. Therefore, we looked into our institution's burn patient readmission rates for the last few years. We performed a retrospective chart review investigating hospital readmissions to the burn service at UF Health Shands Hospital for within 30 days of discharge in order to identify patient factors that led to readmissions. We wanted to not only determine the specific reasons for representation, but also wanted to determine if the recent introduction of Florida's controlled substance law impacted our rate of readmissions. Identifying a pattern in this patient population could lead to changes in our current practice that could enhance the patient's experience and improve outcomes. This was an IRB-approved retrospective chart review of adult patients readmitted to the UF Shands burn service from 2016 to 2018. We collected data from the electronic medical record regarding patient history. We have demographics, burn injury information. We even took zip codes, discharge disposition. We looked at whether the readmissions were planned, unplanned. We looked at the date and time of readmission, and then the place of readmission, the burn clinic versus emergency room, and then the reason of the readmission. So, in a total of 1,249 patients that were admitted and discharged from the UF Shands burn service from 2016 to 2018, 87 of these patients, or 7%, were readmitted within 30 days for any reason, planned and unplanned. Of these, there was a 4.6% readmission rate for unplanned, all-cause 30-day readmissions. And if you recall, the nationwide rate that was presented in the Hodosevich paper was 7.5%. I also give here a breakdown of the rates for each of the 3 years that we had. Here, I present the more demographics of our all-cause readmissions for the 3 years. It's important to note that we included readmissions for non-burn wounds as well, like in STIs, because we also care for those patients on our service. So of these readmissions, roughly a quarter of the patients were non-burn wounds, and 3/4 of the patients were burn patients. Of the unplanned readmissions, infection was the most common readmission diagnosis, 43% of those patients, followed by non-burn, non-surgical related conditions such as pneumonia, UTI, MI, et cetera. That was at 21%. And then pain followed at 13.8%. And within the cohort of patients readmitted for infection and in pain, 16 of 25 and 7 of 8, respectively, were patients that were with burn wounds. So we only had 8 patients of the 3 years that were readmitted with a primary complaint of pain in our 3-year review. 9.2% of the total readmissions, in that roughly estimates a 0.6% readmission rate for the time studied. Of these patients, the total body surface area was 13.6%, which is slightly higher than the 8% for the all-cause readmissions. In relation to the controlled substance law that was implemented in July of 2018, we saw a slight increase in readmission rate from 8.6% to 11.8%. However, analysis was limited based on our small sample size and the time frame that we studied. So we'll need some ongoing review to determine whether the effect of the prescription narcotic limitations on our burn service actually affects the readmission rate. We found that the most common reason for unplanned readmissions to our service was infection, which is not too surprising. 12 of these patients actually had a true infection, and they were started on antibiotics. The average TBSA for these patients was actually only 4.9%, but this is in line with the nationwide study, which showed that most of the patients that returned with an infection had a TBSA of less than 10%. Most of our patients that presented for infection were also discharged home, and when they returned, most of them complained that they had difficulty caring for their wounds, mostly secondary to the lack of supplies and this lack of perception of wound care education. So, we suspected that readmissions for complaints of pain would have increased after July 2018, secondary to this controlled substance bill of Florida. In our review, we found that there was an 11.8% of the readmissions after the bill went into effect were secondary to pain compared to 8.6% before. Well, this could reflect an increase in pain-related readmissions. However, like I said before, more time is needed to fully reevaluate the impact of this law on our readmission rate. Importantly, though, this review revealed that the post-discharge wound care for the prevention of infection would make the biggest impact in lowering our readmission rate. Specifically, our patients complain of lack of wound care supplies, and they have a perception of lack of education, which we plan to better address during our discharge planning. So we'll continue to assess our readmission and add to our database to determine the burn-specific reasons patients are returning so that we have a better understanding of our patient population to revise our discharge practices and better serve our patients. In regards to the wound care supplies, there's been continued discussion with the company that provides the supplies to better communicate the types and amount of supplies that the company sends to the patients. issues that we usually run into have to do with insurance coverage for those supplies. And to combat the perception of the lack of post-discharge wound care education by these few patients, we're actually in contact with our media teams to create a patient education video that can be accessed from the patient's mobile device or computer from home. Hopefully this supplements the reading materials that we send the patients and the patient's family homes with. So I'd like to thank everyone listed here for their help in gathering and analyzing this information for the study, and I will now take any questions for anyone.
Thank you for the opportunity to speak. My name is Katie. I am a plastic surgery resident at the University of Rochester, and today I'm going to be talking about nosocomial burn wound infections and how we have eliminated them with daily wound care. The Kessler Burn Center is an ABA-verified burn center at the University of Rochester. We're very clinically busy with a large geographic catchment area, including Western New York and Northern Pennsylvania. I'm going to be describing our burn wound care protocol that we use on our inpatients, and then report the subsequent burn wound infection rate among those inpatients over a 2-year period. Burn wounds are especially high risk for development of infection, and the reported rates in the literature vary widely between 2 and 39%. And infection is the second leading cause of death in burn patients following injury from the progression of infection to septic shock. And burn wound infections are also associated with an increased length of hospital stay, as well as necessitating the use of broad-spectrum antibiotics, which has risks in and of itself. We performed a retrospective review over 2 years at our institution, and we defined nosocomial burn wound infections as cellulitis of the burn wound or bacteremia without an identifiable cause, which was diagnosed 48 hours or longer after the initial admission, hence the nosocomial portion of this definition. We do not perform quantitative bacterial cultures routinely at our institution, and all burn wound infections are confirmed by the attending burn surgeon or our nurse practitioners and physician assistants that are dedicated to our team. Walking through our inclusion criteria, so we started with all patients who were admitted to our burn service as inpatients, which is 648, and we then excluded 91 patients for having a length of stay less than 48 hours, which would not allow us to meet our burn wound infection criteria for nosocomial infection. 54 patients additionally were excluded for being admitted to our burn service for reasons other than burn, for example, Stevens-Johnson syndrome, toxic epidermal necrolysis, or other NSTIs. And then an additional 13 patients were excluded from this study for having isolated inhalational injuries, as we wanted to focus on our wound care that we perform on cutaneous burns, leaving us with our final cohort of 490 patients over 2 years. Next, I'm going to talk about what we do for our wound care, and importantly, we start our wound care regimen with pre-medicating patients. That typically means in the emergency department on our initial visit, we use IV Dilaudid, and then subsequent days we tend to use pre-medication with PO oxycodone. And importantly for our pediatric population, we both use our child life specialists in helping to distract patients from their burn care, and if necessary, we use a pediatric intensivist to do sedations on our pediatric population. So we'll start by cleansing the wounds with water and chlorhexidine soap, and this is, we think, the most important part of our wound care protocol, which is using mechanical and sharp debridement to remove non-viable tissues and skin, and therefore we unroof and remove blistered skin. And then afterwards, we rinse the wounds with water or saline and pat them dry. Here are a couple of examples of how we do wound care in these patients. So this was a young girl who presented to the emergency department with a scald burn, and this is immediately following our mechanical debridement. As you can see, all of the non-viable skin and detritus has been removed. And then this is 24 hours following that, and as you can see, the burned wound is starting to demarcate with a portion of her shoulder. It has a deeper burn up there. That was the only section of this patient's burn that did require grafting. Another example, this is a flame burn from a house fire, and 36 hours post-burn injury here after we've done our wound care. And then another final example, this patient had a contact injury. He had he'd been throwing debris in a bonfire and then ended up falling into a melted plastic chair that was in the fire, and that's what the dark areas are, is melted plastic. And here is immediately following the initial debridement. As you can see, there are still some sections of this melted plastic that are left behind because we only want to remove the tissues that are non-viable initially, and we try not to traumatize any surrounding healthy tissues, so that remaining plastic came off in the following days. So after our wounds are debrided, we then dress them, and we start with a bacitracin polymyxin B ointment, and we use generous amounts of that, covered by Xeroform gauze, so non-stick gauze, and then we for extremities, wrap them with Kerlix gauze and ACE wraps, or for torso burns, we cover the Xeroform gauze with ABD pads or burn gauze if it's a large area. Some special considerations we have for our burns. So for complete hand burns, we use the same ointment, the bacitracin polymyxin B ointment, and then we cover it with an edema glove as seen here. It's importantly, we don't use this edema glove on incomplete hand burns because it can cause some problems with moist desquamation on healthy tissues. So if it's an incomplete hand burn, we do individually wrap fingers and things like that to save healthy tissues in the palm or otherwise. For face burns, we use petroleum ointment as opposed to the bacitracin polymyxin, and that's because it can be irritating to the eyes. And then finally, for ear or nose burns with exposed cartilage, we use daily mafenide acetate cream and then cover it with fine gauze. So importantly, we perform this protocol daily with our inpatients, and that wound care is continued as an outpatient as well. So for our demographics, the majority of our patients were white males, unsurprisingly, in the age range of 30. However, our range goes anywhere from the age of 0 to 93. And then we had 33% with comorbidities, the most common being active smoking. Our burn etiology was mixed. 80% of our patients did have thermal injuries, either scald, flame, or contact. We did include patients with friction injuries and then other etiologies such as chemical or radiation burns, etc. 50% of our patients had a mixed second and third degree appearance of their burns, and our total body surface area average is 5.7% for all patients. For hospitalization, our average length of stay was approximately 8 days, and 15% required an ICU admission. 32% of our patients did require surgical intervention, and so those 158 patients had 305 separate trips in total to the operating room. And importantly, to distinguish from early excision and grafting, our average lapse between the burn injury date and their initial excision and grafting was 8 days. And importantly, also at the bottom, it does show in our study that we had an average of 23 days until full epithelialization. That doesn't count into when we do grafting of these patients, their wound care regimen is held for 5 days to allow the graft to take, and then we resume that wound care for approximately 7 days. Importantly, in our complications, we found that there were 0 burned wound infections over a 2-year period at our hospital, although there were other nosocomial infections, including UTIs, pneumonia, catheter-related bacteremias, and 1 C. diff colitis. We did have 8 patients who succumbed to their injuries. with multi-system organ failure, respiratory failure, one person with brain death, and a central line associated septic shock. In conclusion, daily wound care performed as we previously described here has demonstrated the eradication of burn wound infections at our institution, suggesting that nosocomial burn wound infections are a preventable complication that otherwise have potentially devastating consequences. In the future, I think it's important to evaluate the burn wound infection rate in our outpatient population, as there may be a discrepancy between the quality of removal of biofilm and non-viable tissues in our outpatient population as opposed to when the nurses or other burn care providers do it inpatient. And ultimately, a randomized controlled trial would be required to demonstrate superiority of our wound care protocol as opposed to other wound care regimens, including early excision and grafting. I want to thank my co-authors, including Dr. Derek Bell, who could not be here today, but he's been so supportive of us, and also Drew Mitchell. And I will take any questions. Thank you.
My name is Jake Long. I'm a plastic surgery resident down in Tampa at the University of South Florida, and thank you very much for the opportunity to present this morning. I have no relevant disclosures to disclose. So this is a talk based upon an article that we recently had published in the Burn Care and Research Journal about an interesting case that we had about a heparin-induced fever. So fevers are common in burn patients, as we are well aware of. They often are attributed to either just the surge response of the burn injury or infection. However, one oftentimes uncommon cause of fevers that we don't often talk about are drug-induced fevers. These are usually seen after the initiation of a drug. They diminish after stopping the drug and are usually not linked to other causes. Oftentimes, culprits considered in drug-induced fevers are anticonvulsants or other antibiotics. However, one medication that is not commonly seen is heparin, and that was what we found in our case. So our case was a 23-year-old female who had approximately 32% total body surface area friction burn after a motorcycle crash. She had also experienced a traumatic knee arthrotomy as well in her injury. Her operative course included an irrigation debridements of her knee wound, ultimately requiring a gastrocnemius flap reconstruction, and then she also underwent excision and debridement and grafting of her friction burns. Throughout her course, when she initially was admitted, she was started on heparin for her anticoagulation. And we noticed approximately 2 weeks after her initial admission and initiation of the heparin, she started experiencing cyclical fevers, which ranged anywhere from 102 to over 105 degrees. These persisted over a 2 to 3 week time frame, over which we performed an extensive febrile as well as infectious workup. She had multiple chest x-rays, blood cultures. Physical exam did not show any infection at the previous knee injury site or flap or around her burns. She had multiple other infectious labs that were also done. She did not have any leukocytosis during these febrile episodes. She did have some initially upon presentation. However, those subsided after her excision and grafting of her burns. She had an echo looking for any cardiac etiology, as well as other ultrasounds showing that she did not have any sort of DVTs or other potential causes of her infection or of her febrile episodes. During this time, she didn't have any significant medication alterations, and therefore we looked at the literature, and the drug that we had looked at was back in 1992. There was only one other reported case of a heparin-induced reaction and fever, and so therefore based upon that literature search, we made the decision to transition her from heparin to Lovenox, which Lovenox has not shown any febrile drug-related reactions. Subsequently, after the switch, her fevers and the rest of her lab work normalized within 48 to 72 hours. So this caused us to look into drug-induced fevers. Usually the onset of the febrile episode is approximately 7 to 10 days afterwards. However, this can vary from 24 hours to up to several weeks. Our patient, as I stated previously, was 2 weeks after her initial heparin administration. The most common pattern seen with these fevers is a hectic pattern, which is intermittent and remittent fevers, which can range anywhere from 99 to over 190 degrees Fahrenheit. The cause of this hectic pattern is related to initiation of other treatments such as Tylenol or cooling blankets, and that's usually the reason why that these fevers show this hectic pattern. Laboratory values are usually not helpful in the diagnosis. You may experience a leukocytosis with a eosinophilia. Our patient did have a slight eosinophilia around the time of her febrile episodes, but she did not have any leukocytosis. Inflammatory markers are usually nonspecific. You may have an increase in transaminase levels. However, these are usually rarely double the normal level and also are returned back to normal after the cessation of the drug. Usually, drug-induced fevers can be discussed in 5 different categories. There can be a hypersensitivity reaction to the medication, altered thermoregulatory mechanisms in the central nervous system. There can be reactions to the administration of the drug or pharmacological action of the drug, and they can also be due to idiosyncratic reactions. Removal of the likely drug is the treatment of choice for the drug-induced fever, and usually resolution is at around 48 to 72 hours afterwards, which is also what we experienced in our case. One interesting aspect with relation to a drug-induced fever is something termed relative bradycardia. This is where the heart rate does not respond as expected with an increase in temperature. Usually for every increase in 1 degree of temperature, there's a subsequent 10-point increase in the heart rate. However, if this does not occur, that is termed relative bradycardia. Patel et al. Has published a calculation based to determine this relative bradycardia. So an example would be if a patient has a 102-degree temperature, you take the last digit, 2, minus it by 1, and then multiply it by 10 and add it to 100. So that would be, for a patient who had a 102-degree temperature, a expected heart rate for that would be 110. And as stated, if the heart rate is less than this expected value, the term relative bradycardia can be applied. This is a graphic representation of our patient's temperatures with relation to her heart rates. And as you can see, the purple line is our patient's values, and the blue line is what would be expected for the heart rate response for those different febrile temperatures. So, for example, when she had a 102.9 or 105.1, her heart rate was 109 or 130, where technically it should have been 119 or 141 for the typical reaction and response to that. So in conclusion, burn patients, we often see fevers due to a lot of times infectious or just the local SIRS response. However, anytime a patient does have an increase in their temperature, an infectious workup should be performed. However, if in a patient we do not have any sort of cause for the fevers, if they have intermittent fevers, relative bradycardia in the setting of normal lab findings, a drug-induced fever is something that we should consider. And then also if a patient is on heparin, there is a consideration of potentially switching the patient to Lovenox if they are medically able to tolerate the switch. These are my references, and thank you very much.
So thank you very much for the opportunity to present. We have no relevant conflicts of interest to report. So the objectives are basically to go through both the expected and usual presentations of SJS-10s as they relate to the burn care specialist, the role and evidence regarding burn specialists in a multidisciplinary management and its effect on mortality, present the data that we have regarding outcomes in a large cohort, and discuss the implications. So as we're all aware, Stevens-Johnson syndrome and 10 or SJS-10 have characteristic full-thickness mucosal and epidermal necrosis, characteristically without dermal underlying inflammation. It is a drug reaction. There is a long and varied list associated. chemotherapeutics, antibiotics, some sulfa drugs, allopurinol, and there's not necessarily a key characteristic associated with them. There is a prodromal viral-like period followed by gross epidermal and mucosal necrosis. The initial lesions are characteristically targeted, demarcated areas of erythema that are painful, itchy, and then can rapidly progress through a spectrum of severity from the most minor being SJS, which you can see this gentleman has sloughing of the vermilion border, as well as a limited area of skin involvement, and progressing up through SJS-10's spectrum through to true TEN. The management is generally supportive. The traditional thinking in terms of IV immunoglobulin therapy is slowly switched to cyclosporin. Some centers, including PAP et al., have noted the fact that in their retrospective studies, the mortality rate was significantly lower with use of cyclosporin rather than IVIG. From a burn specialist perspective, barrier dressings remain an important part of preventing complications associated with this epidermal loss and expectant antibiotic management. The worst prognosis is with full mucosal involvement of the intestine with resultant bacterial translocation. The results available, if you do a literature review on this, are quite variable. Each individual center has its own flavor, has their own management strategy, and reports widely variable outcomes. More recently, 2018 through 2014, the results that I could find demonstrated SJS and TEN anywhere from 15 to 70% inpatient mortality. Although these are all single-center studies or some group studies in the case of European consortiums with 8 to 120 patients over up to 10 to 12 years. As part of this, about 20 years ago at this point, SCORTEN was created to help in terms of prognostication based upon presenting vital signs and baseline characteristics with an almost logarithmic increase up to 90% mortality with increasing numbers of risks. This is more useful in the research setting because it allows for comparison of outcomes, but in terms of challenges in doing outcomes research, at a single center level, you're able to power these SCORTEN calculations with clinical variables, and you have the longitudinal tracking as long as they remain within the health system. But there is a selection bias. There's a specific management style of attending or team of attendings. Consortiums, lower, not as low patient numbers, but there is, again, a selection bias of all being from a specific type of facility. Administrative data has the ability for longitudinal tracking without any bias associated with facilities, and it's quote-unquote all patients, but there is the possibility for bias from lack of reporting of diagnoses, and there aren't necessarily direct clinical variables. So the New York State SPARC system is an administrative database that takes all data from all facilities which have to maintain a set level of contribution that provides the ability to track providers, facilities, and different aspects of patients that allows you to track them for their whole life as long as they remain in New York State. It's non-intuitive, it is very messy, but it's not unique. Other states have this sort of system as well. So New York State in 4 seconds. It's the 4th largest state. It's the 64th largest municipality globally, and it has basically the same ethnic distribution to the U.S. Census, which gives it as a great data set to evaluate how things look at a national level. So what we know, if you were to review the National Burn Repository for skin disorders, in New York State there are 11 burn centers, 2 are ABA certified, and 8 are only New York State recognized. The majority are in the metropolitan New York City area. 6 report to the ABA, and the National Burn Repository is great in providing a lot of variables, but there is a time limit to how much the facilities report. And there are known issues with clustering and missing data and misentered data depending upon the skills of your data entry person. So here's New York State, and in our neck of the woods in Western New York, the red outline indicates that ABA certified. The blue outlines indicate those that are New York State verified, and then the yellow represents those that report to the ABA. So a good sampling in location and distribution. So what don't we know? We don't know the SJS-10's patient outcomes seen at non-burn care facilities and the extended outcomes for them. Who are they? Where are they treated? What sort of interventions they receive? What aspects in terms of specialist centers make in terms of outcomes? And what risk factors affect outcomes out to 1 year post-onset? So the initial hypothesis that we had was that after adjustment, burn centers have a decreased risk of complications related to management at one of these specialist centers. So using the New York SPARS system over a 16-year period and identifying back using ICD-9 and ICD-10 codes and extracting records for all patients out to 1 year pre and post-injury, we designed a data set that used baseline demographics, injury information, including onset, although there is some limitations with the way that the SPARC system is designed, the degree of involvement, and using a modified version of the SCORTEN. In addition, to look at hospital outcomes, I used NISQIP reportable events to evaluate how they did, as well as CDIF, which is not part of NISQIP. Since we don't have clinical variables, I had to modify SCORTEN to get around this. Age obviously doesn't have to change. Malignancy, looking at any heart rate could not be monitored, and otherwise just using diagnoses rather than clinical variables to replicate it. And so basically here's the modified SCORTEN risk state. Management, since we can look at transfers, that allows us to evaluate how changes in care affect outcomes, length of stay, any procedures that were performed, and mortality during the initial care period and 1 year post-onset. These came from the ABA, the New York State Department of Health, SPARCS, and providers using their AMA master file provider ID. I could identify and track outcomes based upon case volume. Using a variety of statistical tests with a p-value less than 0.05 was considered significant. So overall, over the 16-year period, the most common that we see is SJS at almost 70%, with SJS-10 overlap and 10 taking a corresponding about equal component. If you look at the amount of each proportion that had 1 year mortality, it's actually a relatively small portion in comparison to what you would expect through SCORTEN. Those patients who came in through the ED or were otherwise transferred, only about 10% had an initial diagnosis of SJS-10s. Most had prodromal symptoms. Others were on the differential, if you were seeing a new skin lesion, things like cellulitis or other dermatologic skin conditions. And about 40% were entirely unrelated, everything from a broken hip to a heart attack. The distribution of diseases seen at burn centers and not is essentially about the same, except for burn centers seeing a much greater proportion of SJS-10s and 10s in general. This is where I started to get kind of gloomy when I was doing my statistical analysis, because if you start looking at the crude inpatient and then 1 year mortality, the mortality at care facilities that treat burns is almost double that. The way to interpret this table is to look at one column and then the other two columns that correspond next to each other. So the burn centers had almost a 30% mortality risk as an inpatient in comparison to 10 to 16% at non-burn centers. Looking to see if these patients are comparable, there are younger patients at burn centers. They tend to have the same number of comorbidities at baseline. And in terms of looking at the modified SCORTEN, non-burn centers, again, seem to have more patients who receive a score because of their age. Burn centers are more likely to receive scores because of the fact that they see more high-level cases. And interestingly, burn centers, the patients were diagnosed more with shock and acidosis. This pie chart demonstrates for both basically the distribution through the various levels of SCORTEN, from the top right portion being a score of 0, and then progressing in a clockwise fashion around to the most severe of receiving points for all. Most patients fell into the 1 to 2 range in both cases, with pretty minimal differences in distinction. However, in terms of mortality, using the SCORTEN data, you would expect the fact that the patients in the 3 through 6 range would have anywhere from a 40 to 90% risk of inpatient mortality, but it actually falls quite a lot shorter than that. This isn't, a potential criticism of this, the fact that we're not able to pick up diagnoses or clinical variables, but you would actually expect to see the curve being shifted more to the left, and it actually follows a pretty nice curve all the way up into the high ranges. There was a significant difference in terms of the volume seen at burn centers versus not, although this obviously didn't have an impact on the mortality rate. Patients in burn centers stayed longer in ICUs, as well as overall. And there was a difference in terms of where care was received. Obviously, at non-burn centers, they did not have a burn ICU, where most patients were. Although I thought it was interesting that there was a significant portion who were in medical ICUs in burn centers as well. In terms of transfers, up to a third of all burn center patients were transferred from outside hospitals, receiving them about 2 to 4 days after the onset of symptoms. Most providers at burn centers were high outliers in terms of the number of cases that they saw of SJS-10s. Versus non-burn centers, the primary, or the attending of record at the time of discharge was at the median. In terms of complications, being at a burn center led to a higher risk of ARDS, pneumonia, and deep vein thrombosis, whereas shock, sepsis, and urinary tract infections were also significantly higher at burn centers. No difference in C. difficile. So in discussion, if you look at this data initially, it seems scary that there's something that is systemically wrong with burn center care of patients, but I think it's a more subtle thing than that. The longer length of stay, the greater risk of sepsis, ARDS, and pneumonia. Are we starting off on the back foot, given that a third of these patients are coming in later? Is there a diagnostic bias from aggressive workup, given the desire to initiate management for any complications early, leading to more diagnoses? Is the fact that personally, as a burn attending critical care provider, I don't know if I'd feel comfortable managing cyclosporins on my own. Is that sort of delay in assistance from outside providers or consultants affecting the speed in which we initiate immunosuppressives? And also, burn ICUs are dirty. There are many resistant organisms related to the long-term nature of patient care. Immunosuppressives in that environment may be associated with some of these complications. Again, these are all just conjecture. It's hard to interpret some of that aspects from SPARCE itself. The other thing as well is that the risk of mortality extends beyond the immediate management period. About 4 to 10% of patients will die beyond the acute care window. And further work is needed in order to evaluate what those reasons for eventual prognosis are. It could be related just to the constant pro-inflammatory state created by conditions such as this. And ultimately, it would be nice to develop a tool out of something like SCORTEN that allows us to talk to providers in our community about, things that they should be able to manage on their own, as well as those that would be best served in what cases for management of SJS-10s. So I love the title of that paper regarding the Bow score, so I just had to adopt it here. But it is 20 years old at this point. It was based only on 120 patients at a single French center. The mortality risk is a lot lower than what they reported, and I think that's overall something that, at least in New York State, that we should be proud of, and I'm sure they're replicated in other states as well. Was it changes in management, diagnostics, or was it just related to one center's experience? Population-based data can help in terms of developing these sorts of tools, but it's not the end-all, be-all. Like I mentioned, it's challenging. It's a challenge to query and interpret. You're trying to drink from a fire hose while carrying around 40 feet of it. There's no ability to track clinical variables, and there's a misclassification bias from diagnoses not being reported or not being picked up from notes. And some aspects of the timeline of care is missing. So from Sparks, we can't necessarily say what day a patient went to the ICU, what day that a certain condition was diagnosed during a hospital course. So SJS-10's spectrum disorders is not standard burn care. The standard practices and wisdom are challenging to evaluate in this case. And Meliora is our motto, but I think most burn care providers do Meliora, which means ever better. And SCORTEN may need to be reevaluated with the use of longitudinal data. So I'd like to thank Dr. Bell and Dr. Fleming, who obviously supported me, paid me, as well as assisted me in interpretation. Thank you.